with some of the less common disorders in psychiatry. Dissociative disorders are not common, and they are the kind of disorders we say they are good to know. It's good to know because they do exist, but you may go through your whole medical life without encountering any of them, apart from symptoms. There's a difference between a symptom and a disorder. Some symptoms of dissociate, which form the criteria for dissociative disorders. Oops. Changing positions. Oops. It's a good thing I'm not on video so that you don't see me moving from one corner to the other. This is a better corner. So, like I mentioned, you may come across some of the symptoms, but not enough to meet a diagnostic criteria of dissociative disorders. So they're good to know or nice to know, but they're not the kind of disorders where we would expect you to write a short answer question or a short essay, but it would be the kind of question you'd get in an MCQ. Again, I repeat, most people go through their medical professions without coming across them. Now, so you should be able to define and then maybe classify dissociative disorders at a DSM5 and name the important diagnostic criteria. Now, dissociation is about dissociating, scattering, spreading out, separation, and dissociative disorders have been described as disorders in which there's a disruption in the unitary state of self, or in the disturbance or disturbances in the experience of self. Normally, you know who you are, this is me, this is my name, this is where I'm coming from, this is what I'm doing this is where I am today, I'm in the medical school, but and that is you are a one self. But when there's one self, that experience of unitary self is disrupted so that there are two of you, or you don't remember important details about your life, then we say that you're dissociating. So there are some, the resulting is that persons has lost some connections in their thoughts and memories and feelings, and your sense of identity is not so clear. Identity of self, not identity of your, oops, Allah, I wanted to remove this side panel, which should be like, yeah, that's better. So there are some of 5 core components in the diagram. One is amnesia, loss of memory, in other words. Another one is derealization, and we will describe that further because that's one of the disorders. The other one is depersonalization, identity alteration, and identity confusion. So these 5 form the core components of dissociative disorders. The definition of dissociation is a mechanism. It was first described by Freud as a mechanism that allows the mind to separate or compartmentalize certain memories or thoughts from normal consciousness. And this is different from dissociation, as Freud described it, was a defense mechanism. It is not the same as what he described as the ego, the id, and the superego, where sometimes the content of the id is not accessible to the superego. That is not this. This is where certain parts of your experiences, of your memories, are enclosed and they put in a separate place, okay? Compartment, a separate compartment. However, it is also important to note that the content of that compartment which has been put aside is not lost. They are not erased, and they may resurface spontaneously or be triggered by objects or events in the person's environment. So it is not a permanent situation. Now, the DSM-5 classification of dissociative disorder has 5 main conditions. The first one is dissociative identity disorder, also referred to as multiple personality disorder. The other one is dissociative amnesia, including dissociative fugue. The other one is depersonalization and derealization disorder. And the others are the others specified or unspecified. That is where we like to be vague, because the complexity of the mind. So we always have room for others and the unspecified in the classification. Now, let's go to dissociative identity disorder. Dissociative identity disorder is actually more common in Hollywood and in fiction as it is in real life. It doesn't mean it doesn't occur. I mean, you know that the things that occur in fiction, a lot of them are based on real experiences. So of course, we do have a condition called dissociative identity disorder. I have never come across a patient with dissociative identity disorder. I don't know anybody, any of my colleagues who has reported one. I know of a patient who claimed to have dissociative identity disorder himself, but there was no evidence that he actually had a dissociative identity disorder. Now, the first, some of the oldest writings on this is the strange case of Dr. Jekyll and Mr. Hyde. Robert L. Stevenson. You can put it on the chat if you have read this book somewhere in your life. This is a classic, and it's a very interesting classic. I expect that by the time people keep on calling me. So I expect that medical students are all rounders in many senses. That means they have read widely, they have an interest in literature and classical literature. And so anyway, if you've read it, put it on the chat somewhere in the back of in your past. It is the story of Dr. Jekyll in London, who was a doctor during the day and a serial killer called Mr. Hyde at night. And Dr. Jekyll did not know of the existence of Mr. Hyde, and neither did Mr. Hyde know of the existence of Dr. Jekyll. And that is the classic description of dissociative identity disorder. Previously, you find it in textbooks labeled multiple personality disorders. There are several other book films, and some based on true stories on dissociative identity disorder. There is one who had 4 personalities. I can't what was the name of that film? Where there's a, in case you know this film that I'm describing, you can put it on the chat, where there is this personality, a woman in the US, a Black woman in the US, was a society woman, high society, was she a dancer in a nightclub, in another personality, and then in another personality, a child with a very high IQ or something like that. In case you know the film, it's also quite interesting, and it was based on a true story. Now, the diagnostic criteria is there has to be 2 or more identities or personality states, each with its own relatively enduring pattern of perceiving, relating to, and thinking about the environment and self. Amnesia must be part of it, must occur, defined as gaps in the recall of everyday events, important personal information, and traumatic events. So there must be amnesia, and the person must be distressed by the disorder or have trouble functioning in one or more major areas because of the disorder. And the disturbance is not part of a normal cultural or religious practices. And I will explain that. Usually in multiple personality disorder, there is amnesia that the person, Jekyll, what I mentioned, Jekyll did not know about the existence of Hyde, and Hyde did not know about the existence of Jekyll, but they were both disturbed by evidence of the presence of the other. If Dr. Jekyll woke up in the morning and found some clothes which were bloody, a knife, or then he's disturbed. Who comes to my house when I'm sleeping and leaves their clothes there and their knife, which they probably have done something bad with, you see, and so on. Or Mr. Jekyll comes to his house and finds a doctor's instruments, notes. I said, who is this stupid doctor who's been coming into my house? What do they want with me? You know, are they looking for me? You know, and all that kind of thing. So this kind of amnesia of part of life. And the other one is a trauma. Most of these disorders we're looking at are associated with trauma, but there is usually no memory of the trauma. Now we say that the disturbance is not part of normal cultural or religious practices. We know that there are some cultural and spiritual practices in different types of religions, ranging from traditional ethnic religions. By traditional ethnic religions, I'm referring to the religions that do not belong to the classic religions, the Judeo-Christian Islamic religion group, or the Hindu classic religions. But there are other religions where they are, so it transverses all, where people have rituals where people take the identity of another. Sometimes the identity taken of another person within the context of a religious practice would be a person who is a spiritual being, like some saint or so in the Catholics. You see some or in other places. So or in the traditional culture where the shaman takes on the personality of a dead person, a spirit of somebody. I'm not going into that. I'm not very conversant with this, but you could read some of these up shamanism or how it occurs also in classical religions. So that must not be the case. If that is the case, then we do not make a diagnosis of dissociative disorder, or we don't even consider it a disorder in psychiatry. The other thing we need to rule out is Substances, the physiological effects of a substance. You may not be intoxicated with alcohol during that time, or cannabis, or cocaine, or heroin, or any of the others. So it is important that it's not related to that. Two, the most important medical condition you need to rule out is complex partial seizures. Complex partial seizures can have some very complex behavioral and cognitive and personality characteristics. So it may not be epilepsy. Of course, it may not be a tumor, okay? Sitting in certain frontal lobes or temporal lobe. Now, we say that this disorder carries a 70% risk of suicide. Obviously, if you have a condition where during the day you're a medical student and at night you are something else completely different and usually antagonizing the other one, completely antagonistic, maybe like you're you know, I don't know, a call girl or a call boy or whatever, the distress of being when you're faced with the fact that you're a medical student. What were you doing? What were you doing on Kainanga Street wearing some very funny clothes? Me? Never. What do you mean? Of course it was you. We saw you. We even tried to talk to you and you pretended you didn't know us, you know? The whole thing becomes complicated. It becomes so complicated that there's a high risk of suicide. Luckily, I want to again point out that this disorder, dissociative identity disorder, is very rare indeed. So don't worry about it. It's not happening to any of you. So dissociative amnesia is the other one. And the DSM5 classification says including dissociative fugue. That means they put, in the past, there used to be in DSM4, there were two. There was dissociative amnesia and there was dissociative fugue, but now they're in one category. And the defining feature is an inability to recall important autobiographical information, usually of a traumatic or stressful nature, that is inconsistent with ordinary forgetting. We all forget. There are some things we forget. But when something dramatic happens, like you are attacked or sexually assaulted, and thereafter, you forget. It does not exist completely. Gone, gone, gone. That is not ordinary forgetting. So then we can consider the diagnosis of dissociative amnesia, which again, I want to point out that as Freud said, dissociation is a defense mechanism to protect the mind. Overlaps, it can overlap with dissociative fugue. In dissociative fugue is really interesting. Probably occurs more commonly than dissociative identity disorder, but may not be so easily diagnosed. What we do know is that there are a few cases which have been described where the person apparently travels purposefully, takes a bus from Nairobi, goes to Arusha, acquires a new identity, acquires a new memories of a family, and completely his past life is completely gone, finished. And then the other one is the bewildered wandering, where somebody is just wandering around and does not remember who he is, where his family is, or where they're coming from. And this is in the absence of structural damage to the brain. These kind of amnesias, we're not talking about any changes in the brain structure. Nobody hit you on the head, okay? But you had a very traumatic experience. You don't know who you are. You don't know. Or the other one where you purposely buy a ticket, go to Arusha, you live there, you get a job, and you describe a new family. Problem starts when you wake up one morning and revert to your old identity. Or people see you and they say, but you're saying he disappeared 10 years ago, yeah. But I saw somebody who looks like him. We saw somebody who looks like him, and it was very, very clear that it was him. We know him, but when we talked to him, he didn't even speak Kikamba. He spoke a Tanzanian language of Swahili only, and he had a different name and things like that. So these things occur, but not always reported. Some missing people remain missing. Most cause of missing is that you're dead. You died, you were thrown in a forest. Somebody killed him, or somebody killed you, or you killed yourself in a forest and you stayed there. Nobody found you. So people miss, but some people may have dissociative fugue. Again, not common. This is not the thing that you want to jump to when somebody in your life is missing. That's not the first thing you want to come to. Some of the memory disturbances we've mentioned, they could be occur in dissociative amnesia. And most of this amnesia is one of the features that you find in all these, the three disorders we've talked about. Localized amnesia, the most common form, failure to recall events during a circumscribed period of time, mainly around a traumatic event. Again, remember, no structural damage to the brain has occurred. Selective amnesia, where you can recall some but not all parts of the circumscribed period of time. You remember going to town, you remember going to a nightclub, and then from there, you're gone. You forget. You don't have it. So that is selective. Now, there's also systematized amnesia, which is loss of memory of a specific category of information. And in that one, some information is lost and others are not. For example, you may lose the information that you're a medical student, but remember that you have a family. No, you have a family. Then you're saying, I'm not a medical student. I am an engineering student, or I am not even a student, but you know who your family is. So that is systematic. Now, continuous amnesia, which is the loss of memory of each new event as it occurs, meaning that the person is also not storing information. And then you have the generalized amnesia, which is very, very unusual, where acute onset of complete loss of memory of one's life history is all gone, like can happen in a fugue. But the interesting thing is that skills, language is not lost. Skills, if you used to drive a car, you don't forget how to drive a car, okay? So certain types of memory are not actually lost. That the cognitive functions are preserved. And the reading, writing, speaking a language are all preserved. Sometimes language is lost, but it's very rare. Now, the thing about these conditions is that they have a very sudden onset. Like I said, you have a traumatic event, and then you wake up in the morning in your bed. You remember only going to a nightclub. You don't remember the subsequent event. You don't remember, for example, being sexually assaulted, being thrown in a ditch. You woke up and then you crawled home, you slept, and then you woke up in the morning and you're wondering, why are my clothes so muddy? So it's a very, very sudden onset. And the dramatic thing about them is that they can also have a very sudden resolution. So sudden that, and this again increases the risk of suicide. When you wake up when suddenly you realize what happens 1 year down the line, 5 years down the line, you've built a new life, and then suddenly you're in your old one. And the whole trauma comes with all its emotion, then the chances of doing something drastic to yourself is high. Now, we have these two other disorders. These disorders, you'll come across them not as disorders, but as symptoms. They occur, depersonalization and derealization, where depersonalization is a persistent feeling detached from, as if one is outside their body observing themselves, like in a dream. That is depersonalization. These are things that most people experience as symptoms. They're not even symptoms. They're within the normal range of experiences and can happen in normal time, particularly in association with anxiety. You're sitting in your desk, you're waiting for ping to go so that you start that chasing specimens around tables, that thing where people run around tables chasing specimen. You become so tense that for one split second of a time, you're outside of yourself and you're looking at yourself sitting there. But it's very quick. Other times it is within the context of being drunk. You're drunk and it happens, or intoxicated with other substances. But it only becomes a disorder if it is persistent or recurrent, okay? So not that occasional one. And then the derealization is that sudden, very sudden feeling as if everything around you goes flat and unreal, you know? Again, put yourself in that class, waiting to do that exam, and suddenly everything in front of you goes flat, as if it's two-dimensional. But it's just a split thing. You may not even notice, but you know, if you're observant, you will, and then you're back. So again, it is only if they are persistent that we call this a disorder. Now, otherwise, these episodes may also happen during flashbacks of traumatic events. Again, we go back to traumatic events, that every time you have flashbacks of a traumatic, what we call re-experiencing, where you experience a traumatic event with all its emotional content, fear, if it was fearful, painful, if it was painful. Now, in these disorders, unlike schizophrenia, reality testing is intact. That means somebody knows that they're experiencing something unusual, okay? A person with schizophrenia who suddenly finds themselves on top of a tree. They are not on top of a tree, but they think they are. Or they've gone up, or they think they are flying, or whatever. They don't know that this is not real. That is their reality. And this is the thing about psychosis. These people are not psychotic because they know that what is happening to them is unusual and not normal. So reality testing remains intact. Now, the disorder, like in other disorders in psychiatry, we say there must be clinically significant distress. There should be, or socio-occupational impairment. And that is why most of the people who experience derealization, depersonalization really, are not considered to have a disorder, because it is not clinically significant. It doesn't cause distress. A lot of experiences in psychiatry are within the normal range of human experiences, a lot of them. And that is why putting this clause, clinically significant distress or socio-occupational impairment, is one of the criteria for diagnosis of most disorders. Now, the other exclusion, of course, is, as we said, it should not occur exclusively during the course of another mental disorder. Like if it is happening exclusively within the context of PTSD with flashbacks or substance use or a general medical condition or a tumor, then we don't make that diagnosis. Now, lastly, we have these other specified disorders in which the predominant feature is dissociative symptoms that do not meet the criteria for any specific dissociative disorder. We have mentioned 3: multiple personality disorder, disorders of amnesia and fugue, and depersonalization, derealization. So if you have all symptoms but they don't fit in this, then you can make this diagnosis. And that includes some of the presentation that we find in the dissociative identity disorder, that they actually don't quite meet the criteria. For example, if somebody has no amnesia, has memory of being this and that, then you can't just make the diagnosis of dissociative identity disorder, but you can do, say, it's other specified dissociative disorder. And something you need to rule out also is individuals who have been subjected to torture, like forms of brainwashing in captivity, where they have been convinced that you are not Kamau from Central Province, but you are somebody else from another place, whatever it is. So that is not, we don't consider that the same as multiple personality disorder or fugue state, because this is something that another human being has actively made an effort to change your personality. We also, again, don't do this when it is within the context of dissociative trance states and possession trance states. And this is where we talked about cultural and religious rituals. Possession trance states are those states in which a traditional or a shaman will say that they are being possessed by the spirit of somebody else, whatever, all those religious things. So, and where did I? Yeah. In the next slide, we are still ruling out current and recurrent symptoms of mixed dissociative symptoms. That would fall under other specified due to prolonged intensive persuasion, which is almost like the one we talked about, which is the brainwashing in captivity, due to acute dissociative disorders due to acute reaction to stress. Then we would put it under that category. If we don't have PTSD yet, then again, trance state, if not part of a cultural religious activity. So you can make that diagnosis of others if you have a trance state, which is not part of a religious disorder, not religious, which is not part of religious or cultural rituals. So the etiology, this diagnosis, other specified dissociative disorders, allows you to still take an interest and still maybe even follow up, maybe even consider treatment of patients who don't meet the other criteria fully, but are presenting with all these other kind of dissociative symptoms. Etiology, dissociative disorders have been shown to be common among people of the same family, implying a possible genetic predisposition, meaning that in some family, when somebody experiences trauma, they are more predisposed to be dissociating than other people, because some people experience trauma, some dissociate and some don't. The majority of people don't develop dissociative disorders. So there is that question of whether possible genetic predisposition. At the moment, there is no clear, it's not clear which kind of genes are come into question. They've also been found to be closely related to traumatic experiences, particularly in childhood. Traumatic experiences as childhood abuse, combat, we know about combat, criminal attacks, brainwashing in hostage situations, or involvement in a natural or man-made disaster. So they are closely associated with traumatic events, major traumatic event. We have also seen that you may develop symptoms within another condition, like acute stress disorder, PTSD, conversion disorder, somatization. You may have developed dissociative symptoms, but not enough to qualify you as having a dissociative disorder. Now, the epidemiology prevalence of dissociative disorders is unknown. Like I mentioned here in our setting, a diagnosis of dissociative disorder is very uncommon. It is also partly because when people develop some types of dissociative disorders, it is more likely that people will assign them to a spirituality, religiosity, being possessed, being cast, being done, whatever, uchawi, and so they don't come to psychiatry. They go somewhere else. They have been found to be commoner in women at a ratio of 1 to 5. That means women are more likely to develop dissociative disorders than men. And onset is usually in adulthood or late adolescence. In some cultures, dissociative symptoms may occur within the context of religious experiences and trance states. And I think we have mentioned this before, that if this does happen within that context, I think it is better not to include them as a psychiatric disorder. But if it becomes stressful to the person, if it becomes stressful, that I'm always changing from me to Saint Lucia and talking about Maria and whatever, it's so stressful, then you may consider it as others non-specified. But normally we leave the religious ones to sort themselves out within that context of religion and spirituality and culture. Now, the treatment for dissociative amnesia is therapy. That's the first line of treatment, is therapy and not psychopharmacology. It's aimed at helping the client or the patient to restore their lost memories as soon as possible, so that their life doesn't get completely disrupted, because it does disrupt life. If you're a medical student and then you stop being a medical student and Mara, you're this, and at night instead of reading, you're walking around town doing whatever you're doing, then it just disrupts and messes up your life. So of course, it is important to restore the person to a unitary sense of self as soon as possible. One of the methods that has been used is hypnosis. And sometimes pharmacological hypnosis is done using pentothal. Some people have also tried to use diazepam because it's readily available. The problem is that it must be very slowly given so that the person doesn't fall asleep. If the person falls asleep, then it doesn't help. Okay, that is so. I'm not. I don't know that we do not train people to do hypnosis, the other form of hypnosis. So we don't have experts in hypnosis. So it becomes kind of tricky in our setting to help a person through hypnosis. Luckily, like I said, it is one of those conditions which we hardly ever come across. And if we don't see it. So psychotherapy is the mainstay. To bring, you can use the pento, and then you bring back the memories, and then the person commits suicide because it's too much. The brain can't take it. So you have to be very careful. So you have to prepare the person. You have to increase their resilience. You have to give them coping skills to be able to deal with the traumatic experiences that are going to come up. So you need to be very careful with that, because you don't want to be able to bring the person back to who they were and then they commit suicide. That is dramatic. That is not good. So hypnosis is also used. There's nothing else. Psychotherapy, I think I've already said that. The form of therapy, particular for dissociative identity disorder, is it's long-term treatment. The trauma of the past must be explored and resolved with proper emotional expression, even as you are trying to merge these multiple personalities to bring them back, to find out which was the original personality of this person, because what you're trying to do is bring back that one who the person was. Interesting is that all these personality represent certain psychic traits of the person. Yeah. So, but they're not the predominant personality. There are minor traits somewhere which come up and find expression. That is one of the theories of multiple personality, that the personality don't come out of nowhere, but are sort of like minor traits, usually coming from the level of the id that gain expression. So that is all. Let me stop presenting, see if anybody answered any of the questions, and I'm ready to answer questions. Okay, it's a very short topic, and it's good that it's short because, like I said, the significance may not be. Somebody is talking about dreams. How dreams come about. Dreams are usually a reliving of the person's day, sometimes not, but they use some. It is usually an expression of the conscious mind, but using symbols from the id. So dreams are symbolic. Like if you dream about being chased by a horse, it doesn't mean that during your day you were chased by a horse, but it is a very complex theme which cannot just be answered like that. You may want to read some of the more classical books in psychiatry, like the Freud book on interpretation of dreams, because dreams are complicated. It is it's some kind of cognitive process that occurs within the time that you are sleeping. That means they are not conscious, and they are symbolic. And because they are symbolic, the symbols that are used in dreams may not be clear to you. Like if you dream you're being chased by a horse, and you've never even ridden a horse, hmm? Or there are no horses where you live, but you're being chased by one. What does that really mean? It does have a meaning, but the horse may be symbolizing something else. You're climbing a mountain, but every time you're almost at the top, you keep sliding down. You start again, like Sisyphus climbing that mountain, pulling a rock. It may be that the interpretation of that is the same as you would interpret that Sisyphus mythology. What kind of burden are you trying to overcome and not getting there? So there are many ways, and there is no standard interpretation. Like you can say that this is the interpretation for all dreams, but certain symbols in dreams are common in humans, but there is also the cultural context. So it may be that in our culture where horses are not very common, there was one of the interesting Freudian cases was the case of Little Hans. Little Hans was a boy who was terrified of horses, dreamt about horses, and turned out that it had to do with a fear of the authority or of the father or the penis of the father. I can't remember the whole story, but it means that even then, the context of your dreams must remain within what you know and within your cultural background. So your grandmother, if your grandmother has never heard of UFOs, she would not dream about being chased by green men from outer space. She might dream about being chased by ancestors or a shaitani or something like that. But you might dream something different. But it must always be within the context of information that is within your brain. But it is how that is taken and it becomes a symbol representing something else. That is the best I can say now, but there are some books which you can read. Now, let me see. Hello, Doc. This is personal. How can I contact you? You can call me. I'll put my telephone number here at the bottom, and then you can just call me. 0727 329 904. Please send me a message first so that I know who is the number that is going to call me. Because sometimes when there are too many people calling me, then if I see a number I don't recognize, I might not say anything. So, but you can call me. Okay. What about the possessed shaman? Shaman, not I've shared that. Okay. Frankie and Alice, thank you. That was the film. That was film of Frankie and Alice. It is really interesting. Just go and see it. It's about dissociative identity disorder. Thank you very much, Diana. Nobody has read, it looks as, and Grasa Murasi has also seen the film. That I had forgotten the title of the film. I used to have a copy. I don't know where it went. In the days of videos, I think. So nobody has read the book by Dr. Jekyll and Mr. Hyde. I'm disappointed, but it is okay. I'm allowed to be disappointed. The movie that you mentioned is Astral Projection. You've taken me very far with astral projection. This is part, astral projection is part of the Buddhistic religion, and it is not depersonalization. I would treat astral projection within the context of Buddhism and Hinduism. And it was a question by Lydia Chipkoesh. Maybe she's been reading some Buddhist books on the Buddhism and Lobsang Rampa. What was the name of that guy? Anyway, whatever it was. So we do not, that is not depersonalization. Is emotional detachment. No, it is not. Emotional detachment, emotional numbing is not a dissociative disorder. It can be a dissociation, but not a disorder. It is not a disorder, it is a dissociation where you're trying to detach, compartmentalize your emotional, with not to feel. It's a kind of a defense mechanism around dissociation, but it's not a disorder. The disorder might be something else. It may be PTSD. In PTSD, you get emotional detachment or numbing. Okay, Suresh has read the book and Lillian Godho has read the book. Now I'm not disappointed anymore. Thank you very much. Dr. Jekyll and Mr. Hyde has been read. Thank you. What is the difference between selective and systematized? Selective amnesia, we said, is where only part of the amnesia, only certain bits of the amnesia have been absent. A certain part of memories are absent. That means you can remember some things, but you cannot remember all of them. The other one is specific to a category of information, like maybe you forget your historical background, some history, around independence or whatever, but other things you remember. So history is a category of information. Family history or biography is a category of information. You remember all other things, but everything that refers to your family, you forget, okay? But selective, you just pick from here.
Recording
you remember, some things you do not. Thank you for stopping recording. So that is selective and systematized. Sleep-related is no. I don't know any sleep-related dissociative disorders, because when you are sleeping, you have sleep. If things are happening when you're sleeping, then you are having sleep disorder, like sleepwalking or automatism and things. These fall under sleep disorders. We talk about dissociative disorders happen in full consciousness. Reshare your contacts. Okay, I'll reshare. Disorders. Okay, let me just type it here. It's just a phone number if you want to get in touch. 9904. And the email is, you can use the university email. But you must give me a subject that I will make me alert to the content. Otherwise, I might not. Have you got it now, Bashir? Or did I? It has refused. Ah, yeah. I thought I tried.
It's okay. It's
Have
okay.
you got it? Okay.
Whoever wants the number can reach out to me. I can send them.
Good. Okay. Then get it from
Khan.
Yeah, from Khan. Khan has the number. Okay, fine. If there are there any other questions?
Yes, Professor.
Yes.
I wanted to inquire if Lavin had asked you about today, 5 p.m. If you can cover the class.
Today.
Yes, classification
today.
of psychiatric.
What are we missing?
Classification of psychiatric disorders.
No, she didn't, but I can do it today.
Today, 5 p.m. 5 to 6.
Yeah, it's okay. 5 to 6.
You, Professor.
Yeah.
Yes, I will send you a link.
Okay, good. Okay.
Great.
Okay, thank you. Bye.
Bye, Professor.